Hello everyone, I'm Dr. Naveen Kumar Bandari, a second year radiology postgraduate from MNR Medical College, Telangana. Today I'm here to present my paper under the title Role of Ultrasound in Diagnosis and Follow-up of Patients with Rheumatoid Arthritis. I've done this paper along with my HOD, Dr. A. Rohini. Coming to the introduction, rheumatoid arthritis is a chronic systemic inflammatory disease affecting the synovium, bones, tendons, and ligaments. When it is affecting the synovium, it can cause persisting synovitis, which can lead to structural damage of the cartilage. The classic radiographic signs of rheumatoid arthritis are osteoporosis, bone erosion, and joint space narrowing. The presence of this bone erosion has a considerable implications over the treatment and prognosis of the disease. Though regression of this bone erosion seldom happens in patients who took the treatment, it cannot be used as an indicator for treatment efficacy. And therefore, the conventional radiographs which show this regression of this bone erosions cannot be used as an adequate method to evaluate prognosis after the treatment. Grayscale ultrasound enables accurate visualization of the inflamed synovium, joint fluid, and para-articular changes. Color Doppler and power Doppler are also used as an excellent tools for visualization of the blood flow in inflamed joints so that the stage of inflammatory changes can be estimated and the efficacy of treatment can be evaluated by analyzing the decrease in synovial thickening and also reduction of vascularization of this thickened synovium. Aims and objectives of my study were to evaluate the role of grayscale and color Doppler ultrasound in diagnosis and follow-up of patients with rheumatoid arthritis after 6 months of treatment by comparing qualitative and quantitative ultrasound parameters to several standard clinical indicators of the disease activity. The study design differed from previous studies because the cutoff values of resistance index, which might indicate the presence of active disease, were determined before and after the treatment. An additional aim was to examine which hand joints can be examined and which can be omitted so that we can reduce the examination time during the follow-up of the patient. Materials and methods, inclusion criteria. This prospective study consecutively included 30 patients with rheumatoid arthritis in whom adequate ultrasound examination can be performed on all joints. Out of these 30 patients, 21 were women and 9 were men with the age range of 17 to 79 years and the age median being 53 years. Exclusion criteria, the patients with large deformities in whom ultrasound cannot be performed properly were excluded. Ultrasound examinations were performed at the baseline and after 6 months of treatment on the day of clinical examination. We also took the disease activity scores and calculated them. All the patients were examined at MNR Medical College, Sangareddy, and on the day of examinations at the baseline, we also took the conventional radiograph of both hands of each patient so that we can determine the stage of the disease and the presence of bone erosions, subluxations, and luxations that will prevent us from technical performance of the ultrasound properly so that we can exclude them from the study. Technique, grayscale and color Doppler ultrasound were used to evaluate morphologic changes of the inflamed joints, assess the degree of their vascularization, quantify the spectral changes, and assess the effects of treatment after the treatment, and compare these ultrasound findings with the clinical findings and laboratory inflammatory parameters. Examinations were performed on ulnocarpal joint and metacarpal joint and proximal interphalangeal joints at the baseline and after 6 months of the treatment. Total 22 joints of both hands were examined, that is 10 metacarpal joints, 10 proximal interphalangeal joints, and 2 ulnocarpal joints in each patient using high frequency probe. In our institute, we used GE Logic F6 machine, and the presence of effusion, thickening of the synovium, and joint erosions were examined. Findings were characterized into 4 groups. First, the joint effusion was characterized into 4 groups. If there was no fluid, it was given group 0, minimal fluid group 1, moderate fluid group 2, and large quantity of the fluid in the joint was given group 3. And synovial thickening and bone changes were also noted. And color Doppler findings were used to estimate the degree of vascularization of the inflamed synovium, and we characterized those findings also into 4 groups. If the inflamed synovium had no vascularization or zero vascularization, it was given group 0. And if the thickened synovium has minimal or only one blood vessel is supplying the thickened synovium, it was given group 1. And if the thickened synovium has more blood supply, but it is less than half of the thickness of the inflamed synovium, it is given as group 2. And if it has more vascularization, but it was occupying more than half of the thickened thickness, half more than half thickness of the thickened synovium, it was given group 3. This image show the different groups of the thickened synovium. This is the thickened synovium with only minimal blood supply, which was given group 0. And this picture indicates this was a thickened synovium with more blood supply, but occupying less than half of the thickened synovium, indicating is group 2. And more blood supply occupying more than half of the thickened synovium is group 3. Results, changes of the laboratory parameters, disease activity score 28 and HAQ. ESR, DS28 and HAQ score significantly decreased after treatment compared to the baseline values, and the p-values were calculated using the t-test for sample pairs, and the changes in HAQ and DS28 scores indicated successful treatment as the disease activity was reduced. Rheumatoid factor values were also significantly reduced, and CRP values were also decreased, but not significantly decreased post-treatment. This is the table showing values at baseline and post-treatment values. The values of ESR, DS28, disease activity score 28, HAQ, rheumatoid factor, and C-reactive protein values. These values are significantly reduced when compared to the baseline. Changes in qualitative sonographic parameters, such as bone erosions, synovial thickening, and synovial effusions, which were evaluated on the grayscale ultrasound. The number and degree of joint erosions did not change significantly between the baseline and end of treatment, whereas the synovial thickening significantly reduced in 7 out of 12 metacarpophalangeal joint and ulnocarpal joints, and synovial effusion decreased significantly in 2 metacarpophalangeal joints. The case with proximal interphalangeal joint is that the joints were too small to be examined. There was a technical difficulty in examining these joints. They were smaller, and the inflamed synovium was too small to be examined, and it is even more difficult to detect the and estimate the vascularity of the inflamed synovium in this proximal interphalangeal joints. Therefore, we excluded this proximal interphalangeal joints in our study. And the changes in quantitative Doppler parameters, the spectral Doppler findings, the quantitative spectral parameters of peak systolic velocity, end diastolic velocity, and resistivity index were measured on color Doppler and power Doppler. And after treatment, resistance index increased significantly in 4 joints, which indicated the successful treatment. The peak systolic velocity decreased significantly in 3 joints, while end diastolic velocity decreased significantly in 5 joints. This is a table showing the baseline and post-treatment values of the spectral Doppler findings, that is the resistivity index, peak systolic velocity, and end diastolic velocity values in ulnocarpal joints and metacarpal phalangeal joints in both hands. You can see that the resistivity index, when compared to the baseline, has increased post-treatment, and the peak systolic velocity and end diastolic velocity significantly decreased post-treatment. This is the images of the pre-treatment, that is at the baseline image, and this is at the post-treatment image, showing the decrease in the extent of the vascularity. Here you can see that there is increased vascularity to the thickened synovium, and also it is less than half of the thickened synovium, which means it is group 2. And post-treatment, the thickened synovium is decreased firstly, and then the vascularity also decreased to group 1. And when we calculate the resistivity index at the same place, the resistivity index pre-treatment was 0.5 and post-treatment it was 0.6, which means the resistivity index decreased. The thickening of the synovial thickening decreased, and then the degree of the vascularization decreased from group 2 to group 1, and the resistivity resistance index has increased. This is the overall table showing all the quantitative and qualitative parameters. The synovial thickening, effusion, and vascularization decrease significantly. These are the qualitative parameters, and the resistivity index, PSV and EDV, are the quantitative parameters in which the resistance index increased, and the PSV and EDV decreased significantly post treatment. Discussion, we demonstrated that color Doppler ultrasound features can be analyzed in metacarpal phalangeal joint and ulnocarpal joints, and that successful treatment results in reduction of PSV and EDV and increase in resistance index. Changes in quantitative Doppler parameters were observed in both ulnocarpal joints and in 5 out of 10 metacarpal phalangeal joints, and our results indicate that resistance index of less than 0.4 could be used as an threshold value to diagnose clinically active cases, while resistance index of more than 0.5 could indicate successful treatment. The qualitative and quantitative Doppler parameters reflect the stage of inflammatory hyperemia and provide the information that cannot be obtained in conventional radiographs. The ultrasound has considerable advantages to other imaging modalities. Here we compare it with conventional radiograph because it is non-invasive, because it is there's no radiation involved in it, and it is cheaper and it is easily available. Therefore, we prefer ultrasound, and it is also giving additional information over conventional radiograph. The color Doppler ultrasound examination should therefore be a part of the follow-up algorithm of patients with rheumatoid arthritis during the treatment. And for accurate estimate of the treatment efficacy, the patient has to be examined in a similar fashion before and also after the treatment. Conclusion, grayscale and color Doppler ultrasound are useful to detect changes in hand joints in patients with rheumatoid arthritis and to monitor the effectiveness of the treatment. Ultrasound parameters highly correlate with the laboratory and clinical indicators of the disease activity, and the reduction in synovial thickening is the best grayscale indicator for treatment efficacy, while Doppler findings that correlate with clinical improvement are decreased vascularization accompanied with elevation of RI and decrease in peak systolic velocity and end diastolic velocity. The novelty of this research is that it demonstrated the importance of quantitative Doppler parameters, and it found that cutoff values of RI of 0.4 at baseline and 0.55 after the treatment indicated the presence of active disease and the efficacy of treatment respectively. We found that only ulnocarpal joint and metacarpal phalangeal joints should be examined, while proximal interphalangeal joints can be omitted from examination protocol, which is an important finding for the clinical utilization of the color Doppler ultrasound in rheumatoid arthritis. Thank you.